talk a little interesting, I've taken a case of cervical spine cord injury case, and how I've used assistive technology for this particular case. And I would like to, put my perspective as an occupational therapist, because majority times we are, constantly looking for restoration of functionality, and we are, looking at how we can regain the hand function constantly, and how we can make the patient engage in the self-care. Okay, so and self-care work, leisure and play, like how Dr. Murli and Dr. Deepa have also mentioned about that. So right now, because I'm focusing on assistive technology, the moment we say assistive technology, we are looking at two different situations. Either it's a irreversible loss of the structure or function, or it's just a temporary assistive technology which can actually promote, active participation, so that the person there's a neurological recovery along with the natural recovery which happens in the spinal cord. So it facilitates the recovery as well. Pain point where I frequently come across when we are trying to prescribe assistive technology is accepting the technology itself, because majority people, they are upset because of loss of their natural function. And the we need to have effective evaluation for the technology. What kind of technology should be provided, how do we design, how do we fabricate, and ensure it meets the desired outcomes, not only from the clinical end, but also from the patient side, because unless they use it, it won't make any difference for them. So in my practice, there are three E's which I try to follow when I am trying to prescribe assistive technology for patient management. So first is effective evaluation of the needs, which for which we need to understand what is the core etiology. For what reason has the spinal cord got involved? Is it a trauma? Is it a tumor? Is it an infection? What is causing it? Is it demyelinating? Is it progressive, non-progressive? Because basis of that, how much do you want to convince the patient for assistive technology, and what kind of technology should you should prescribe to the patient becomes critical. If you engage them and provide them a technology which is very high end, and we know that this condition is going to resolve sooner or later, we actually are making them spend money in a tech which may not be required in long term. So this is just one example. Second is effective designing and fabrication facility. As of now, where I work, we have a team, we have a collaborative team. It's more than a multidisciplinary team. It's a collaborative team where engineers and doctors are working together. So we get a very hands-on experience working with the engineers, as well as the other clinical staff who are actively handling patients on ground. It also includes the neurosurgeons and the neurologists to get a very good feedback from them. Third is the essential checkouts and the training strategies. If we provide a technology, or if you're providing assistive device, let it be high end or a simple low end tech, which I will show forward, without proper checkout and training, most of the times they are left unused, and the entire effort of identify the need of assistive technology and management does not land on the ground as we think as a team. So when I say it's a collaborative approach, what does it mean? The foremost, it's a patient caregiver centered, and the primary consultant's opinion, because someone who has operated the spine and stabilized the spine will have a really good idea about how the internal structures are and what kind of damage has happened inside. Following which, we need an effective rehab evaluation. So we, based on the level of injury and the physical as well as the cognitive impact of the injury itself, you may need a physical therapist or an occupational therapist or speech language pathologist or a cognitive therapist to come in and engage, right? So right now, because as a OT I'm speaking, so I'm trying to speak more about the hand function. But if someone has a high level cervical spine injury where the diaphragm is paralyzed and you're on tracheostomy, you really need a speech language pathologist to come and effectively check if the swallow is safe and is he ready to decannulate and close it, because that actually helps them to engage better with the technologies like a computer device, or a device which can work on voice commands. So as simple as that. Even getting a neck control helps them to engage with a lot of devices using the inbuilt assistive technology in the computer these days. Along with that, we need a social work and a financial counselor, because majority of them who are working now, they would be off the job, and how will they return to the job? How are they going to earn money and sustain or continue to use the technology what you're providing them becomes very critical. Then we need good engineers who are not only ready to understand the nuances of the patient care on ground, and the family's burden, the caregiver burden, but also know what is the best tech which can support in the least cost and can be used not only in the clinical setup but can be sent out to home and to the workplaces so that it makes a difference. Then you need a product designer, because this is the guy who's going to design things for you, right? So a product designer who has a sound, I would say a visual perceptual capability, and understand what are the needs and how what are the needs, how the design should be, like previous speaker they spoke about ergonomics of the device. So it's very important. So how are they going to use it? And then we need investor, because if you want to go on large scale and you want to provide it for the society, you need someone to invest. We cannot burden all the patients with the all the expenditure for the devices. We should have some way to ease them out. So let me take you through the story. So our hero here is a 33-year-old high-function individual. He is himself a data analyst. That means he is an engineer who is far more advanced in the field of engineering than me as an occupational therapist, right? And this guy, he was traveling back to his hometown, going to meet his I think she has a 3-year-old girl who he had taken a vacation and going home. And while traveling back in the night, his bus met with an accident. And in the accident, he had a high level cervical spine injury, and that left him paralyzed down the neck. So because though it was a C6, C7 level, we were expecting some amount of neck control to come in, but because of the cord, the edema in the spinal cord, it took a long time to resolve. Even getting a neck control and the shoulder, movements became tough, because of which he was on a long time on the tracheostomy. The diaphragm was yet not functional. Now, this guy himself, he was a a very highly acclaimed professional in the field. He was working. He works in a very affluent company. Because of confidentiality, I cannot reveal the name of the company here, but the company is good enough to fund him for all his needs, not only personal but professional as well. By nature, he's a perfectionist, so he doesn't take things as easy like how any other person would take. So he needs everything perfectly planned and perfectly delivered, right? So he actually underwent screw fixation, and as I was telling you, his traumatic SCI Asia grade A C5 level injury. But unfortunately, because of the edema, it took a long time for him to recover from the weakness which the spinal cord injury produced in his case. Now, why did I choose this case? Because all of you would have seen similar cases. It's not like he is the only guy who has a C5 level. There were two things which pushed me beyond my knowledge of assistive tech. So one is he just refused to accept his fate. He was convinced, like he convinced the company to buy a motorized wheelchair, provided he can use it himself. So he wanted his hand function to come back. He was that adamant about it. And second is he didn't want any high-end technology per se, because he was very clear that he has a grandfather. Sorry, he has his elderly father and a wife and a kid. So none of them know how to take care of electronics at home. None of them know how to maintain it. Even if he buys it, how will he get transferred into it? How to use it? So it was a big challenge for them. So even though we convinced him multiple times as a team and convincing him, because he himself had a resource to obtain these things, he still continued to request for a simple, easy device which can help him to work first so that he can earn money. So eventually, through his rehab journey, I think it took almost 6 to 8 months for us to get him to the at least the fundamental functionality of sitting, turning in the bed, sitting, without support, and he started regaining certain control around the shoulder and the scapula, and he got control of the elbow flexion and extension. But beyond that, we didn't get any recovery. The forearm movements, wrist, hand, it was very difficult for him to maintain them, or the endurance to hold it in a different position.
Last one
That's
minute.
the
Last one
yes,
minute.
yes. Sir. So based on his structural limitations and activity limitations, we looked at how we can get him back to her job. So we looked at a simple half walk-up sprint along with a custom-made typing device, and it took us 2 to 3 weeks to train him, and he was back to his actually able to use the system again. So this is just image of the orthosis as well as the device which we fabricated. Now, interestingly, after 6 months, we realized that the stem it was cracking because of the property of the material. But then he ordered again, and because of the measurements, we could make another pair. So let me just check if the video plays. Yeah. So this is him trying to use his system again. So you can look at, despite the limitation of the forearm, wrist, and hand, how effectively is able to type. So this is as good as any one of us who can actually type on the system, right? So just for the okay. So I'll unfortunately the PPT is hung. What I want to conclude is next what we have done is we have made 3D models of it so that we can mass customize it, and it does not need, once you have fit in the measurement, we have different sizes of the typing device. That means the stick part of the typing device. So you can screw and unscrew it, and you can use it for different people. So mass customization, understanding the patient's need on the ground, and understanding the ergonomic strength, the anatomy, the physiology, fundamental the human's capability, and looking at how it can be optimized for the patient use on ground becomes critical when we want to prescribe assistive technology. So, sir, just because of the lack of time, I would like to conclude my talk here, and I am open for any kind of